What's up, Ninja Nerds? In this video, we're going to be talking about multiple sclerosis. Before we get started, the most absolute best way that you can support us here at Ninja Nerd is by subscribing, hitting that like button, and commenting down in the comment section. That enables us to continue to make videos for you guys' enjoyment all across the world. So Ninja Nerds, let's get into it. All right, Ninja Nerds, so let's start talking about etiology and pathophysiology of multiple sclerosis. So first thing, when we talk about multiple sclerosis, there's no completely defined causes, but what we do know is that it is a particular type of autoimmune disorder. It's a type 4 hypersensitivity, meaning it's a cell-mediated type of reaction. Now, things that we've kind of traced back as potential etiological factors come down to environmental and genetic types of things. So environmental, these primarily involve infections. So was there some viral infection in their history? And the two viruses that I want you guys to remember is Epstein-Barr virus and human herpes virus type 6. I'll explain what their relationship will be in a second. The other one, and we don't know how this one is, but we noticed that people with multiple sclerosis, there seems to be a higher kind of incidence rate farther away from the equator. And what we know is that people with low vitamin D levels, which are generally maybe having less sun exposure farther away from the equator, have higher incidence rates of having multiple sclerosis. Again, how that is, we don't completely know. The genetics that are behind this, because when you have an autoimmune disease, there has to be kind of two components involved. An environmental component and a genetic component combined. That genetic component it's believed to be some type of susceptibility genes. And the susceptibility genes that we've kind of traced this back to is HLA-DR2. So there's a particular type of mutation polymorphism within this gene that basically are present on antigen-presenting cells, okay, which are dendritic cells, macrophages, B cells, when they are exposed to a particular type of antigen, like what? Maybe Epstein-Barr virus, maybe human herpes virus 6. They develop this immune reaction to it that is exaggerated. It's beyond what the normal immune reaction is. The other thing that we see with the genetic component here is that it seems to be more common in those with the XX chromosome, so those who are biologically female. And to add on to that, an epidemiological aspect of this, we see this primarily in younger females, generally anywhere from 20 to 40 years of age. Okay? So what do I want you to take away from this? The things that we've traced back to is environmental and genetic and autoimmune type of reaction, type 4 hypersensitivity, big thing to take away. Two viruses have been seen, Epstein-Barr, human herpes virus 6. Things that we don't know, but we see a relationship or correlation is low vitamin D levels, farther away from the equator, and genetic susceptibility genes like HLA-DR2, and we see this more commonly in the XX chromosome, genetically female, in 20 to 40 years of age. Now, how does all of these things come together? That's what we really should try to understand. So let's say here we take an antigen-presenting cell. So here's an antigen-presenting cell, and this type is just a macrophage. I could have picked any of them, I'm just picking that one. And this antigen-presenting cell is exposed to a particular type of antigen. Let's say it's one of these viral agents. We're just going to, for right now, we're going to put antigen of some kind. Because it doesn't just have to be these things. It could be things that we don't know about yet. What happens is the macrophage will engulf the antigen. And what's that called whenever you engulf an antigen? It's called phagocytosis. So from this process, it'll take and engulf that antigen and express a piece of that antigen on its membrane surface, on what's called MHC2 complexes. Now you know another name for these MHC2 complexes are the HLAs, right? Particularly the ones with the DR, DQ, and the DP types. Well, what happens is when it expresses this antigen on the MHC2 complex, it then will take and present this antigen to a T cell, a helper T cell of some kind. And this helper T cell, if we were to draw this bad boy up here, here's our helper T cell. This helper T cell has a particular type of T cell receptor that can recognize that antigen. And when it recognizes that antigen, it's then kind of primed for that antigen to recognize that anywhere else in the body if it ever experiences it again. So now watch, this type of reaction should occur here where you have this connection between the macrophage, where it's exposing that antigen to interact with the T cell receptor. And then there also has to be some molecules that connect between these, right? So you know there has to be like a CD CD4 positive type of molecule present. Either way, when this interaction occurs, your T cells will start kind of releasing a bunch of cytokines and start proliferating. But now the big thing is we have a T cell, a T helper cell, okay, which has a TCR, which can recognize a very particular type of blue antigen. Now, here's what's weird. These blue antigens may look like a particular protein that we'll talk about a little bit later. A protein that's present within myelin. So there may be a protein called some type of myelin basic type of protein or other types of myelin proteins that look like or almost have a very similar configuration to that antigen. And so now your T cell receptors, they're supposed to recognize that antigen, but guess what? They recognize proteins within our body that maybe mimic that antigen. It's called molecular mimicry. And that's the mechanism by which this can happen. All right, so let's take this T cell that we've pretty much primed and put it into our circulation, right? And track it. As we track this T cell, okay, look what happens. It gets to a point of the body where it enters into what's called the blood-brain barrier. What's the blood-brain barrier made up of? We're not going to write them all down, but I want you guys to think about these three components here within the blood-brain barrier. The first one is the endothelial lining, right? Which has lots of nice tight junctions there. Then the second one is this green layer, which is the basal lamina. It's a nice little connective tissue layer. And the third one is this like little weird looking blue thing here. It looks like an octopus. It's called the astrocytes. So the foot process of the astrocytes are particularly the part that make up your blood-brain barrier. Now the blood-brain barrier is very selectively permeable. It only allows for certain things to come in. So you have to either have particular channels or proteins that allow for things to move from the blood and enter into the tissue where the neurons and other different glial cells are. So the T cell is granted access in certain times where it says, okay, I'm going to come over and just kind of take and peruse around the actual neural tissue, because the blood-brain barrier is going to allow for me, it's going to provide specific types of means for me to get into the blood-brain, past the blood-brain barrier. Once this actual T cell gets in to where the neural tissues are, it migrates its way to the neuron, where it comes into contact with a very particular structure that it notices. You see this little guy here? This little pink guy, this is called your oligodendrocytes. They're called the oligodendrocytes. These are the ones that myelinate the axons in the central nervous system. Well, guess what? This is myelin. Myelin has particular proteins that can resemble some of those antigens that we were exposed to in the past. And what it'll do is, it'll say, hey, I recognize you, I've seen you before, you're not normal, you're an antigen I've seen before. And it starts to adhere and interact with that. Once it interacts with some of the myelin basic proteins that are associated with the myelin or the oligodendrocytes, it becomes activated and says, hey, this something is not normal in here, guys. I need to let everybody else in the immune system know. So then it starts releasing very, very particular types of molecules. What are these molecules? I'm so glad you asked. It releases molecules like interleukin-1, interleukin-6, and tumor necrotic factor alpha. I feel like you guys, if you guys have watched our videos before, you've heard of these cytokines like a million times, right? And what these guys do is they do a couple things. One is they go up and act on the particular endothelial cells within the blood-brain barrier and says, hey, I need more white blood cells to come to this area. So what I want you to do is I want you endothelial cells to increase the expression of little types of like adhesion markers, so that way whenever white blood cells are coming past, they can stick to you and come to the area of where I want them to come. So that's the first thing, is that we have to express some cell adhesion molecules there, okay? Second thing that it does, it also says, hey, why don't you blood vessels also undergo some vasodilation mechanism? So it triggers what's called vasodilation. Why is that important? Well, if you vasodilate a blood vessel, you make it bigger and more blood can flow through there. If more blood can flow through there, more white blood cells can flow through there to come to this area. Guess what else it does? So not only does it stimulate this process called vasodilation, so this would be the second thing I want you to remember, but it also increases the permeability between these actual endothelial cells. So what's that called? It's going to allow for things to leak through. And so it's going to not only cause vasodilation, but increase the capillary permeability. And if you increase capillary permeability, which is the third thing that I want you to remember, more white blood cells can leak out of that blood vessel, come to this area where this actual problem is. So we've increased expression markers, we've caused the vessel to dilate, and we increase cap permeability. The other things these can do is that they can actually get into the bloodstream. And if these little cytokines, we'll represent them with these kind of like dots here, get into the bloodstream, imagine here there's other types of lymphocytes. So there's more types of lymphocytes here. So here, let's say here's another lymphocyte, and it's like, hey, there's some cytokines over here. I'm going to start moving to wherever this injury is or wherever this type of problem is. So it can also stimulate another thing here, the fourth thing, which can kind of create kind of like a chemotaxis type of mechanism. It also releases one more cytokine. Another cytokine that I want you to remember is called interferon gamma. And this interferon gamma will actually also work out here. It'll actually get out into the bloodstream. And you know there's very specific types of white blood cells that it wants to trigger and cause to come to this area. You know there's macrophages. And macrophages love to be stimulated by interferon gamma. So interferon gamma will also do what? Here, let's represent interferon gamma. It'll stimulate these macrophages, activate them, and cause them to migrate to wherever this area is. So that would be the fifth thing, is that you activate macrophages. So to recap, before we kind of come into this area and start damaging this neuron, what were the things that happened? Exposed to the myelin, release cytokines. Cytokines that were released trigger increased expression of these cell adhesion molecules, vasodilation, increased capillary permeability, chemotaxis of lymphocytes, as well as interferon gamma to cause macrophages to come to the area. Now, these things come to the area then. Let's bring in here more lymphocytes and let's bring more macrophages. Once these, let's represent the lymphocytes here in blue. So we're going to switch the color of these lymphocytes just so that we don't confuse them, because these are a different type of lymphocytes, okay? Different type of lymphocytes. So we're going to bring over here the lymphocytes, and then we're going to bring over here our macrophages. Okay, guess what the macrophages do? Macrophages, now that they've been activated, they're going to come to the area, and what do macrophages do? They eat. It's going to want to start coming and eating and engulfing these oligodendrocytes. But guess what? You know what macrophages love? You take a piece of toast and you spread some jam on it. They love it when you make things a little bit tastier. So these B cells, when they're stimulated by all these cytokines that come to the area, they also convert into a special type of cell. You know what kind of cell they specialize into? An antibody-producing factory, baby. It converts into what's called plasma cells. And these plasma cells start popping out antibodies that are specific to the proteins present on the oligodendrocyte or on the myelin sheaths. And so it'll tag this oligodendrocyte or the different components of it. Guess what? Macrophages love that. And they come in, they're like, I'm gonna engulf you. And it comes and engulfs or phagocytoses parts of these oligodendrocytes. So what I want you to remember is plasma cells will produce antibodies. So let's kind of put here, let's kind of add on here, the sixth thing to happen here is antibody production, which is important for tagging these oligodendrocytes and myelin sheaths. And the seventh thing is, I want you to remember for this last part here, is that these macrophages will undergo phagocytosis. Of what thing? Particularly these oligodendrocytes. So now, as you start breaking down these oligodendrocytes, look what happens as a result of this. If we were to put an arrow to represent the actual end result, look at this. Look at this poor little oligodendrocyte. It got all jacked up. Now that it got all jacked up, and we ripped off pieces of myelin, some astrocytes and other types of cells will come to the area and start putting on actual scar tissue. And as you start causing scar tissue to form, this leads to these things called plaques. Okay, so you start forming these things called plaques on the axon. You know what another name for this plaque is? Sclera. And this happens to multiple neurons. And so over time you cause plaques or sclera to develop on multiple neurons, which is called multiple sclerosis. Dang, we good, man. So that is the process by which this thing can occur. Now, here's the nice thing. Our body in certain types of multiple sclerosis, primarily relapsing-remitting multiple sclerosis, there's another immune system cell that we should just be so thankful for. That it says, hey, I realize that the immune system is having a rough day. Let me come out here and let people know to chill and calm the heck down. This cell here is another type of T cell, but it's called a T regulatory cell. Okay, regulatory T cell. It secretes a lot of cytokines that try to kind of really shut down a lot of this inflammatory reaction. So it releases things called interleukin 10, transforming growth factor beta, which says, hey, stop all of this madness that's going over here. Let's calm down. Let's let the nervous system calm down and allow for these oligodendrocytes to try to remyelinate and try to heal. And sometimes there will be a little bit of healing. There may be, here, we'll just put right here, during that time period where these kick in, there maybe be some minimal kind of healing or remyelination that will occur. But then guess what? That doesn't last long. Another immune reaction will occur, start damaging more neurons, leading to this consistent damage over time. Okay, now that we got that, let's talk about the different types of multiple sclerosis. All right, so what I want us to do is talk about the different types of multiple sclerosis. This is extremely important. And the first one that I really want you guys to spend the most time remembering out of all of these is relapsing-remitting multiple sclerosis, abbreviated RRMS. This accounts for 90% of the MS types. It is the most common by far. Now what happens in this is what we described in the pathophysiology, and that's why it's so important. So let's say that we take time here on the x-axis and disability, which is presenting as neurodeficits, in a particular graphical representation on the y-axis. So what happens is, let's say that here we have a time where a patient is having no types of bouts or flare-ups of their MS, and then all of a sudden they have a bout where they experience some type of neurodeficit. Maybe it's a visual change, maybe it's weakness, maybe it's sensory loss. But whatever it is, they experience that bout where they have a flare-up. Then they have pretty much a remission where they'll have some time to heal a little bit, but then what will happen is, after that time period, they'll have another bout that'll occur. And they'll have, again, more injury, maybe more visual changes, maybe more weakness. And then after that, they'll have some time to heal, but they won't completely heal, and they'll have another bout. And this will just keep happening and happening. Here's something that you should notice with this. There'll be every single time, this was their initial disability, right? So let's say that this was their initial state of neurological function. Every time, look at how much neurological function you knock out consistently with every bout. So this is measuring the disability. The neurodeficits are getting worse as time goes on. There may be, after that bout, a little bit of time of healing, remyelination, but you never get back to that complete baseline. Okay? This is the most important one that I want you to remember. The next one is called secondary progressive multiple sclerosis. Now this one is usually someone starts off with relapsing-remitting multiple sclerosis, and then what happens is it kind of progresses in a particular way. It secondarily generalizes into this progressive MS. So they may have that same kind of thing, where they have a bout, and then they go into this remission, and then they have a bout, and then they go into this remission, and then after that, they just have this constant steady state of demyelination, neurological deficits, and disability. Okay? So that's secondary progressive MS. Now, these are the two big ones that I want you to remember. These other ones down here are less common, but they're very severe. Okay? This next one that I want you to remember is called primary progressive multiple sclerosis. So we had relapse-remit. This one has relapse-remit and then constant. This one's just constant. Constant demyelination and disability the entire time. It'll look like this. Okay? So consistent disability the entire time. No time for remission, healing, remyelination. The last one is by far the most severe because it's kind of like progressive and having a relapse on top of that, but with no remission. So watch this. You have this time where you're having a constant demyelination. Then that constant demyelination, you develop an acute flare. But it never goes back to at least the baseline. On top of that, you just go back into a constant state of demyelination and disability. Then you'll have this next state where you'll have an acute flare-up. As it tries to come back down, boom, you'll have another demyelination event. So it's this constant demyelination with relapses that are built on top of that. Pretty nasty, scary stuff. All right, so quick recap so we remember all this stuff because we got to remember it, right? Relapsing-remitting. You're going to have these relapses with a period of remission, but you never gain true function. There's a time period of a little bit of remyelination, but you have this kind of bouts, flare-ups with remission between, okay? Secondary progressive, you have these relapses, these bouts where you have a little bit of remission, but then it progressively gets worse at a constant rate. Primary progressive, constant demyelination throughout the entire time period. And then progressive relapsing multiple sclerosis is it is continuous demyelination with these bouts or flare-ups that are built on top of that. Okay, now let's talk about clinical features. All right, so now let's talk about the clinical features of multiple sclerosis. This is a very, very high yield component of the lecture that we got to talk about. So first things first, one of the first earliest manifestations of multiple sclerosis is demyelination, right? Because that's what this is, a demyelinating disorder, but affecting the oligodendrocytes. What is the only cranial nerve that is actually containing oligodendrocytes that myelinate it? Cranial nerve 2, the optic nerve. So if we demyelinate the optic nerve, we're going to lead to optic neuritis. This is called, what is this called? Optic neuritis. And so with optic neuritis, what does the optic nerve do? It's involved in vision. If we demyelinate, we destroy these actual oligodendrocytes that myelinate the axons of cranial nerve 2, we're going to alter the electrical potentials that are being sent via the optic nerve to your cerebral cortex. And so this can lead to manifestations such as decreased visual acuity. And you know what else? You know, there's this particular photoreceptors that are present within the retina that pick up color, and that's carried via the optic nerve. You also develop color vision abnormalities. So there could be particular color blindness or abnormalities that are present there. Okay, so color blindness or abnormalities. Okay? The last thing that I want you guys to remember here is that a very important physical exam finding, if you're taking a pen light and shining it into their eyes, and you're going back and forth from one to the other, when you shine it into their pupils, instead of them actually constricting, they'll dilate. What is that called? We talked about it in our cranial nerve video. It is a Marcus gum pupil, but also known as a relative afferent pupillary defect. So what do we call this? We're going to write it as a relative afferent pupillary defect, but on your exams, remember a Marcus gun pupil. Okay? These are the big things. So again, remember optic neuritis, decreased visual acuity, maybe some color vision loss. They have a very important thing called the Marcus gum pupil. You shine a light into both eyes. When you go from one to the other, they dilate, okay, rather than constricting. Okay, beautiful. The next manifestation, there is a structure in our brainstem. You know, here we have the vestibular nuclei, and they receive information from the vestibular nerve that comes from our inner ear, right? Well, these vestibular nuclei will tell information to our sixth nerve nucleus. What's the sixth nerve? The abducens. It'll say, hey, abducens, I want you to go ahead and stimulate the lateral rectus of that same eye. So these will go to the lateral rectus of the same eye, ipsilateral. But then what else it'll do is, it'll send this kind of tract upwards that'll stimulate on these two nerves here. What is this tract here that goes up and stimulates these two nerves that are located within the midbrain? Let's write these down. This first one here in red, I'm just going to write down here, the Roman numeral is 3. So what is this? This is the oculomotor nerve. And then in blue here, which one is this one? This is the trochlear nerve. The main one that I want you to focus on is the oculomotor nerve. And so just to be consistent here, the pink one here is going to be the sixth cranial nerve. So we have 6, 4, 3. They're connected via this little tube, this pink tube here, called the medial longitudinal fasciculus, this thing right there. And there's 2 of them, right? This would be on the right, and this would be the medial longitudinal fasciculus on the left. It's connecting these 3 structures together. Guess what? In MS, there's a lot of this structure loves to get damaged. And so you lose a connection between the 6th nerve nucleus and the 3rd nerve nucleus. What does the 3rd nerve nucleus do? It'll send via the oculomotor nerve to go to the medial rectus on the ipsilateral side. Okay? So now here's what happens with this. If you damage, let's represent this here in black so that we're completely clear of what structure is being damaged. This structure here is being damaged. The connection between the 6th nerve and the 3rd nerve. What will happen as a result of that when you have a patient look right, look left, follow your fingers inward, or have them just look straight? That's what I want you to remember. Because the condition that you see with this, when you damage both of these, is called bilateral, we're going to abbreviate it, internuclear ophthalmoplegia. What does this look like? Let's talk about that. All right, so this is a very, very important thing. So when you get out in the clinical field, you know what this is supposed to look like in a perfect world. So let's say that I'm going to kind of represent here, have the patient look to the right or follow your fingers, in this case, to their right. When you do that, remember, what is the structure that's being damaged? If you're knocking out both bilateral medial longitudinal fasciculus, the sixth nerve is firing because the sixth nerve, its fibers are going up straight to the lateral rectus. Okay, that's not being hit. It's the connection to the third nerve that's being hit. So if you have them look to the right, their right abducens is going to fire and it's going to cause them to abduct their eye. But it's going to be so intense that when it abducts, because it has no kind of like opposition by the oculomotor nerve, it's going to do it so fast that it creates kind of like a little nystagmus, if you will. So you'll have them look to the right. That lateral rectus will pull the eye to the right nicely, but it'll have a little nystagmus. Now, if this was, let's say, the right lateral rectus that was firing, it should send signals to the left third nerve. The left third nerve will then go to the medial rectus on the left eye. It should cause it to go and move this way as well. But it's damaged, so it can't do that. So this action will not occur, the adduction. And so it just stays kind of in that midline. But boom, we good. All right, next one. You have them look to the left. The left sixth nerve is firing. There's nothing wrong with that. So it's again going to move to this side, but it's going to have no opposition by that medial rectus because the oculomotor nerve is not connected. So when it does this and it looks to the left, it creates a nystagmus in that direction. Now, if the left sixth nerve is firing, it should send signals to the right third nerve nucleus to go to the right medial rectus. But because that right medial rectus is not going to receive signals, is it going to be able to beat in toward the adduction side? No. So we'll not be able to adduct, so they'll be able to look to the left with the left eye, but that right eye will just stay in the center. Okay? If you have them follow your finger inward, they'll be able to do that. Why? Because when you have them look to the right, it's based upon like the vestibular ocular reflexes, right? Which has to go through the sixth nerve. But if you have them just follow your finger, that's in primarily your third nerve. You're not depending upon the medial longitudinal fasciculus for this. So the medial longitudinal fasciculus is not involved in this action. So it's just your third nerve nuclei that are firing without the medial longitudinal fasciculus. So they'll be able to do that. So if you have them bring your finger inwards towards them, they'll be able to converge. Okay? So having the accommodation kind of reflex, or bringing your finger closer to them, they'll be able to converge. Okay, they'll have a positive convergence on that. The last thing is if you have them kind of just look straight at you, and this is usually if it's really severe, if the six nerves are firing, okay, and sometimes a little bit too much, and there's not much opposition by that third nerve, they can kind of, the lateral recti can actually pull the eyeballs a little bit out more towards that lateral side. And so you might even develop kind of an exotropia bilaterally. So there may even be a little bit of a bilateral exotropia that's present at rest when you're just having them look straight at you. Okay, usually this is as you get a little bit more severe, but these are the things I want you to look out for with bilateral internuclear ophthalmoplegia. Let's move on to the next manifestation. All right, so what's the next clinical manifestation? The next one is that, okay, we talked about the eyes, we talked about kind of the brainstem that is connecting to the eyes. The other thing I want you to remember is another aspect. So I'm just kind of moving down, right? So we got the eyes, we got the brainstem. There's some other aspects that are involved within the brainstem. So you know there's these fibers that come from the cortex, from like your primary motor cortex, premotor cortex, all of those cortices, and send these fibers down from the cortex and come and give innervation to particular cranial nerve within the brainstem, such as which nerves? This is what I want you to remember. Okay, first one is cranial nerve 5. The next one is cranial nerve 7, which is the facial nerve. Cranial nerve 5 would be the trigeminal nerve. The next one is the blue one, which is actually going to be a bunch of them. This is actually cranial nerve 9, cranial nerve 10, and a little bit of cranial nerve 11. And then the last one here in pink is going to be cranial nerve 12. So you have these purple fibers that are coming from the cortex, coming to this aspect of your brainstem and giving innervation to these cranial nerves. These fibers here in this purple color is actually representing what's called the corticobulbar tracts. Now these are myelinated by oligodendrocytes. So in a person who develops multiple sclerosis, we're going to demyelinate these bad boys. And so then you lose proper innervation to cranial nerve 5, cranial nerve 7, cranial nerves 9, 10, 11, and 12. This condition is an upper motor neuron type of lesion called pseudobulbar palsy. What is this called again, guys? Say it out loud. Pseudobulbar palsy. Now, with this, how would it present? We're not going to go crazy. I just want you guys to think about this logically. Let's not have to write down tons of stuff. What does trigeminal nerve 5 do, the motor component? Chewing muscles. If that's affected, you're going to have decreased chewing. Simple as that. Let's not make it too complicated, right? There is another aspect of this where it is involved in the jaw jerk reflex, and because this is an upper motor neuron lesion, what would happen if you tapped on their jaw? It would create a brisk type of jaw jerk reflex. So they would have a hyperactive jaw jerk reflex if you really went the distance of that. Okay, but let's not focus too much. Just decrease chewing. The next thing is facial nerve. What does it do? Facial expressions. So if that's affected, what's going to happen to the facial expressions? They'll have absent facial expressions. Boom, done. Let's move on to the next thing. These two combined actually, okay? Cranial nerve 9, cranial nerve 10, cranial nerve 11. Okay, the motor components of those are involved in the muscles of speech and the muscles of swallowing. So if you jack those up, what's going to happen? Dysphagia for difficulty swallowing and dysphonia for difficulty with speech. So they can develop dysphagia and they can develop dysphonia with the speech production. The other thing, it's an upper motor neuron lesion. When you do things like reflexes, there's a reflex where you tap the back of the tonsils and it's supposed to trigger a gag reflex. Because it's an upper motor neuron lesion, they'll have a hyperactive gag reflex. Again, not super big that you know that, but it's just taking into consideration upper motor neuron lesion type. Cranial nerve 12 is involved in your tongue movements, but it's also involved in speech, particularly the articulation of speech. If you jack up 12th cranial nerve, not only will you develop what's called a spastic type of tongue, it can affect speech in a particular way that it leads to maybe some dysarthria. Okay, so think about that as well. All right, but that's the pseudobulbar palsy. That's the big thing, okay, done. So we got optic neuritis, bilateral internuclear ophthalmoplegia, pseudobulbar palsy. What's the other thing that I want you to remember? It demyelinates a lot of other tracts within the nervous system and our higher order brain centers. And if you involve some of the higher order centers, like your limbic system, like the cortex, you start really leading to some involvement of memory centers, like your Papez circuit. And so they can develop maybe some decreased memory. And you may also alter some of the neurons that are involved in serotonin release and lead to depression. So these are some of the higher order level types of symptoms that you would see in these individuals. Okay, potentially maybe demyelination of some of the components within Papez circuit or involvement of serotonin neurons. The other thing is, there's lots of white matter tracts that are present within the cerebellum, coming from the cerebellum or to the cerebellum. You demyelinate those bad boys, you alter a lot of the things that are involved in coordination, and this can lead to ataxia. Okay, and one of the big things, I can't stress this enough, how they can present with this is when you're doing a test called the finger to nose test. As they bring their finger to their nose and to the clinician's finger, as they get closer towards that person's finger, the tremor will increase. What is that called? It's called an intention tremor. That is extremely high yield. I want you guys to remember that, please, okay? All right, the next thing that I want you guys to remember, this is a sign that whenever they present this, it's going to be on the exam because it has someone's name on it. It does not mean that you're going to see this all the time in clinical practice because guess what? There's a lot of other diseases that do this. But when a person flexes their neck It creates this electric sensation or pain that runs down the neck, down the spine, and even can run into the extremities. You not only see this in MS, but you can see it in like any kind of cervical myelopathy, cervical spondylitis, but it is a very common thing that they'll ask on the boards with multiple sclerosis. And this is called Lermite's sign. Okay? And again, it's this, we have that little electric or a sensation that you can feel in the back of the neck, down the spine, and into the extremities. Another sign that you need to remember, because it's going to be asked on your exam, they love to throw in people's names, it's a very specific type of sign, okay, or phenomenon, if you will. It's called Uthoff's phenomenon. Now, what happens with this? And people with multiple sclerosis, they're going to have a lot of these deficits that we've already talked about and even more. But whenever you increase the temperature, and usually in a vignette, it'll be like the person's in a hot tub, they got a hot shower, something like that, they got a bath, their symptoms of weakness, visual disturbances, sensory changes, anything like that is worse at higher temperatures. The thought behind this is that higher temperatures, in particular neurons, and some cells it doesn't do this, but in particular neurons that have been demyelinated, it's generally going to, higher temperatures already decrease the action potentials down these neurons. Now, if a person already has a demyelinating disorder where the action potential is being conducted down, it is already lower, and you increase their temperature, now the action potentials will be even lower than it was before. That's going to worsen their weakness, worsen their sensory changes, worsen their visual abnormalities. But what's important about this is that usually it'll kind of be reversible. After they start to cool their body down, they'll go back to whatever their baseline was before that. Okay, it's not a permanent type of thing. Big thing to remember there, okay? All right, so we've talked a lot about how multiple sclerosis demyelinates a lot of particular cranial nerves like cranial nerve 2, how it affects the brainstem, the cortical bulbar tracts. We talked about other aspects of the brainstem. We've even hit the cerebellum and higher order centers. But we got to talk about the spinal cord, and that's a big one to think about because it does demyelinate a lot of axons within the spinal cord. So you have to remember your tracks. I'm not going to go through all of them. We're going to hit the biggest things. Now, this track here in pink is your dorsal column. Now, what is the dorsal column sensations? Do you guys remember? Because what we're going to do is we are going to demyelinate these axons. And so whatever sensations are carried by these is going to be diminished to the point where it could even be absent. So what are these? You're going to decrease your dorsal column sensations. I just want you guys to tell me which dorsal column sensations we could be dropping. Think about them. This could be dropping proprioception, fine touch, discriminative touch, vibration sense. Any of those could be potentially diminished and at worst case scenario absent. The next one that I want you guys to be thinking about here. You see this tract here, which is on the lateral white column. So we hit the dorsal column, but here in the lateral white column, there's this red tract. It comes from the cortex down through the spinal cord, and eventually it'll give axons that'll stimulate here these lower motor neurons near anterior gray horn and cause it to go out to those muscles. This is your corticospinal tract. If you knock out a corticospinal tract, what type of lesion is that? Upper motor neuron or lower motor neuron lesion? Upper motor neuron lesion. Really quickly, how do upper motor neuron lesions present? What are the classic highlights? You will have weakness. What about tone? Increased tone, so we call that hypertonia. What about reflexes? Hyperreflexia. What about particular pathological types of reflexes? You can have a particular one where you scrape the bottom of the foot and it causes a dorsiflexion and fanning of the toes. It causes a positive Babinski's. These are some of the big things I want you to see that you can see with this condition. All right, next one here. You know, this here, particularly within the thoracic spinal cord. In the thoracic spinal cord, you can demyelinate some of the preganglionic motor neurons of the sympathetic nervous system. And in the sacral aspect of the spinal cord, you have parasympathetic. If we have decreased autonomic nervous system innervation to particular organs, like which ones? To the bladder and to the last part of the GI tract around the rectum and the sigmoid colon, what can happen as a result? you can develop two things. With the actual sympathetic nervous system, remember it controls the sphincter muscle, right? Because it has the alpha-1 receptors present on it. If you damage that, you may cause that to do what? You may lead to them having that relax, and then they can have incontinence. But if the parasympathetic is affected, that causes contractions of the bladder and causes contraction of the large intestine. If that's damaged, you can't contract those. So you could also develop retention. So in some ways, you can develop a little bit of urine incontinence, but you may also have potential for retention. And then same thing with the fecal system, you may have the same kind of concept here where you can have incontinence and then in some ways retention as well. Okay? All right, beautiful. Move on to the next one. We have another tract here. These tracts are conveying particular types of sensation from the extremities that are carrying what type of sensations? It's carrying pain, temperature, crude touch, pressures. This is our anterior and lateral spinal thalamic tract. If you damage these, you could cause decrease pain, temperature, and so pain, temperature, crude touch. And one last one, pressure sensations. Okay? Boom, roasted. Move on to the next. And the last one here is you have these tracts here in orange. So you have your ventral spinocerebellar tract and your dorsal spinocerebellar tracts, which are carrying information from proprioceptors to the cerebellum that are involved in telling us position sense. If you knock these out, you lose the position sense and become uncoordinated. What is that called? Ataxia. So they can also develop, if you damage these bad boys, they can develop ataxia. All right, so the last thing I want to make sure that you guys know of before we move on to diagnosis, there is a common triad that gets asked in your exams, and it helps you to also kind of like a brief review of everything. And so this is kind of the big triad that you see in patients with multiple sclerosis. It's called Charcot's or Charcot's triad. And the particular things that you need to remember is that these patients will present with nystagmus via that kind of thing we talked about with the intranuclear ophthalmoplegia. They can also present with dysarthria. Sometimes this is written as what's called a scanning speech. Okay, and we talked about that before. And then the last one is they also have those intention tremors, which we see with the ataxia. So again, please don't forget this. This is extremely high yield. You might see this on your exams. It's kind of a nice quick review of what we talked about. All right, let's talk about diagnosis. All right, so now let's talk about the diagnosis of MS. And I want us to focus on the big stuff. So what is the first line? If they ask you on an exam, what is the first line diagnostic test for multiple sclerosis? You'll say an MRI. But let's be a little bit more specific. Let's say an MRI of the brain, and you should also obtain the spinal cord, because this involves both of them. And you should say with and without contrast. So we're going to get an MRI of the brain and spinal cord with and without contrast. Now, I want us to briefly remember what were some of the areas that you needed to remember. The first one that I want you to remember is it affects the periventricular white matter. This is an extremely important one. It's actually one of the first ones to get affected that you'll see on imaging. The second one that it loves to hit the brainstem. So you're also going to get your brainstem involvement. So you have to watch out for that on the MRI. You're also going to hit the spinal cord. So we'll look for lesions of that on the MRI. And then the last thing is we also know that it can hit the cerebellum. So you're seeing these white matter lesions are going to show up all over, man. It can be very, very nasty stuff. Okay, so this is the big things that I want you to realize. Now, when we get an MRI, there's two particular sequences that I want us to notice. T2 and T1, particularly the T2 flare. T1 is your anatomy image. And when you look at this, usually the lesions will show up as dark. Okay, or we call them hypo-intense. For T2, they'll show up bright or white, and we call this hyper-intense. The last thing that I want you to do is sometimes in people who have MS and they have an acute flare-up, if you give them contrast, it will actually enhance the acute lesions rather than the ones that were already occurring in the past when you've had damage, okay? So these will highlight. Big things that I want you to take away from this, okay? So now let's take a look at an image of an MRI. All right, and before we move on to this second line test, just remember, we talked about the MRI, but we actually use MRI and other particular types of qualification criteria in a very specific name called McDonald's criteria. And there's actually a revised McDonald's criteria, but that's used to enhance and aid in the actual true diagnosis of MS. All right, so what is our second line test? They say on the exam, what's the second line test that you can do to determine if someone has MS? The second line test that you can have is called visual evoked potentials. And this one's actually really cool because it should make sense to us. What was one of the first types of structures to be damaged in MS? The optic nerve. If you apply a visual stimulus to them, a very particular types of visual stimulus, and it's supposed to hit the retina and then travel down the optic nerve. If the optic nerve is damaged, what's going to happen to the conduction potentials down the optic nerve to show up on the screen in a graphical representation? The action potentials will be reduced, so the conduction velocity will be reduced. So they'll read this as what's called a low conduction velocity based upon the graphical representation when you do these visual evoked potentials, because the optic nerve is demyelinated. Man, we're smart, guys. All right, what's some extra tests? They're not like definitively diagnostic, but they just aid in the diagnosis. This is where you can go as far as saying, let's get a lumbar puncture. Why would we get a lumbar puncture? Well, we're smart and engineers. Let's think about this. What were the particular things that were produced? I remember I told you there were some antibodies that our plasma cells produced. I didn't say what kind, but generally the one that those plasma cells, if we were to go ahead and draw them again, remember the plasma cells infiltrated into the brain tissue? And when those plasma cells infiltrated into the brain tissue, they produced antibodies. Well, these antibodies are actually IgG antibodies, and they can kind of get deposited into around the cerebral spinal fluid, so they can show up. So one of the things that we can see is lots of IgG antibodies. Now when they put this on an electrophoresis, it has this banding type of pattern that we see to it, and we call that, this is high yield, oligoclonal banding. So this might show up on the exam. It's just a lot of these IgG antibodies that are being produced by the plasma cells in that pathophysiological reaction. And when you put on the electrophoresis, it creates that banding type of process. The other thing is there were so many cells that were infiltrating into the tissue, right? There were not only these B cells and plasma cells, but there were also T cells. And what were the other type of cell that was actually infiltrating into there? The macrophages. What do you call it when you have lots of cells kind of just infiltrating into this particular area when they infiltrate? It's called pleocytosis, an increase in the number of cells. So we have a pleocytosis. Primarily, it's going to be consisting of lymphocytes and macrophages. Man, we're good. Okay, so again, what was all of this called where we actually had to tap in and pull some of that CSF and collect it into tubes to find all this stuff? This is called a lumbar puncture. And so this would tell us this particular type of information. Okay, let's talk about treatment. All right, so treatment. There's two big things that I want you to remember. We have acute treatment when they have these acute exacerbation. What do I mean by acute exacerbation? So let's just say they come in with a very significant like visual deficit. Okay, so they're decreased visual deficits, or they have extreme weakness or paralysis of some type. When they come in with an acute type of deficit of this kind, you have to have an acute therapy. And so the first line treatment in this that you have to remember is high dose corticosteroids. So high dose corticosteroids. And so we can use things like methylprednisolone, prednisone, anything like that. But what I want you to remember is, why do we give this? Corticosteroids are great anti-inflammatory types of agents. So you remember when that T cell was releasing all those cytokines like interleukin-1, interleukin-6, TNF-alpha, all of those dang things, even the interferon gamma? These glucocorticoids are designed to be able to inhibit that process, to inhibit a lot of these cytokines and their effects on the vascular system, which is to induce vasodilation, increase capillary permeability, increase the expression of molecules, cause chemotaxis, all that stuff that we talked about. It's trying to really shut that down. All right, so let's say that the IV corticosteroids, the high dose, don't work. What's the next option? What's the second line option? They ask you this on the exam. You say, plasmapheresis, baby. I'm gonna clean that blood. So how do we do that? It's a very cool system. Now, we're trying to clear out particular pathogens from the plasma. So in this case, we'll say there's some antibodies that we're trying to clear out that are causing some problems, which they are. We're gonna have this, like, let's say the blood's flowing this way, right? as it's flowing, it'll get sucked into this like tubing, right? Get pulled through this kind of like chamber, this sifting chamber, that'll yank out some of those nasty like molecules, antibodies, and put them into this container. Then it'll run through the chamber and then through this other system. As it runs through this other system or tubing that we're gonna put back into the blood, we get kind of this like plasma from a particular donor or some type of like thing like that, saline solution with other types of molecules that we put back into this tubing to run back to the patient. And we give them back the plasma that we kind of took away, which was trying to clear away some of these problematic molecules. Pretty cool, right? So that's the second line. So if they say first line, you say high-dose corticosteroids because it's shutting down the inflammatory action. If they say second line, you say plasmapheresis. Now, there's also supportive therapies. Sometimes, remember, with the upper motor neuron lesions, they get spasticity, the high tone, a lot of that, that we talked about there. You can give them antispasmodic agents. There's things like dantrolene, there's things like baclofen, so on and so forth. They also get paresthesias because of you hitting the dorsal column and spinal thalamic tracts. So you're going to give them maybe gabapentin, pregabalin, tricyclic antidepressants of some kind. And they're also going to suffer from depression, which we talked about, so antidepressants are very helpful in this scenario. So giving supportive treatment on top of the acute exacerbating treatment is important. But what's the final thing that we got to do? We got to try to prevent, let's kind of suppress their immune system a little bit to prevent them from developing these flare-ups in the future. So how do we do that? Let's talk about that. All right, so prevention is primarily geared at like immunosuppression in a way. Now we're not going to go through all of these types of immunosuppressants. I'm going to give you some of the most important ones that you should remember for the immunosuppression occurring in the prevention of acute flare-ups in MS. And the big ones to remember here that I really want you to remember is interferon beta. Interferon beta is designed to be able to inhibit those T helper cells when they release all of those cytokines and all of those inflammatory molecules. That's what they're designed to do. Okay, so interferon beta is designed to inhibit the T cells from triggering that entire inflammatory cascade. Another drug that's also important is called gluteramine acetate. And gluteramine acetate does the same thing. It also inhibits the T cells from that cytokine release. But it does something else really interesting. Imagine gluteramine, I'm going to draw like a G here. It has little proteins on it that kind of resemble some of the proteins on myelin. And so whenever the T cells try to come and interact with the oligodendrocytes, guess what they actually interact with? The gluteramine acetate. And gluteramine acetate will inhibit those T cells. So it kind of acts as a decoy in a way. So that's pretty cool. So you inhibit the T cells from cytokine release, but also gluteramine acetate acts as a T cell decoy because it has proteins that mimic the myelin. The next one here is actually a drug. It's an antibody. The last two are antibodies. It's called ocrelizumab. One heck of a name here. But what it's designed to do is to inhibit the activity of these different types of B cells. Remember the B cells that came to the area? It's trying to inhibit the activation of these B cells. It's also trying to inhibit the activation of the plasma cells. So basically the end result is to decrease the antibody production that is occurring by these cells. Pretty cool, right? And the last one is called another antibody, monoclonal antibody, and it's called natalizumab. Natalizumab. And this one works by inhibiting lymphocytes, right? So your B lymphocytes and your T lymphocytes from invading and crossing the blood-brain barrier and coming to that area where they trigger that massive inflammatory cascade and demyelinating process. Pretty cool. So there's so many other ones, but these are the most important prevention meds that I want you guys to take away. That covers multiple sclerosis. All right, Ninja Nerds, in this video we talk about multiple sclerosis. I hope it made sense. I hope that you guys enjoyed it. As always, Ninja Nerds, until next time.